So, uh, Good evening, everyone, and welcome to this session on the National Future Training. And today we have chosen a topic that is, lung metastasis in pediatric solid tumor. It is a commonly errored subject in the sense that most of the times these lung metastases are mismanaged or they regress after neoadjuvant chemotherapy. And then, this is a common site for recurrences as well. Hence, we thought that we will keep this topic and to moderate this session, we have Dr. Kalashekar with us, who is assistant professor in Regional Cancer Center, Trivandrum. And we have an expert panel, Dr. Girish Chinnaswamy, who is professor and head pediatric oncology at Tata Memorial Hospital, Mumbai. We also have Dr. Shalini Mishra, who is a consultant pediatric surgeon at Rajiv Gandhi Cancer Institute, New Delhi. And from representing radiation oncology, we have Dr. Srinivas Chelgur, who is a senior consultant at Apollo Proton Cancer Center in Chennai. So I think I would request Dr. Manas for a couple of words and then we can start.
No, I think just thanks on behalf of PHO chapter for everyone who has joined for this meeting. I'm sure it's going to be a very interesting session. Thanks to Kala, Dr. Girish, Dr. Shalini, and Dr. Srinivas for pitching in for this topic. And hopefully we'll have a very fruitful discussion. And thanks to Vasudev and Shruti who are helping in this coordinating of this session. So we have planned for one hematology and then alternating it with the oncology. So this time it's the oncology turn. So over to Kala to take it forward. Thank you.
Yeah, thanks, Manas and Vasu. Just wanted to confirm whether you are able to see the slides.
Yes, we can see.
Yeah,
so we can hear you.
Yeah. So good evening, one and all. So today, this topic is on lung metastasis in common pediatric solid tumors. So the esteemed panelist, which has been already introduced, Dr. Shalini Mishra, Dr. Girish Chinnaswamy, and Dr. Srinivas. So let us move on to the topic straight. So lung metastasis, as we all know, occurs in 10 to 30% of pediatric solid tumors. The most common site of distant metastasis. So survival outcomes, if you see, non-metastatic is always the best. Lung only metastasis somewhat like intermediate outcome. So beyond lung mets, like a bone and bone marrow mets, is going to do poorly across all solid tumors. So approach to lung metastasis varies, depends on the type of tumor and depends on the response to the tumor. So that solid tumors which commonly metastasize to lung include bone sarcomas like Ewing's and osteosarcoma, soft tissue sarcomas like rhabdomyosarcomas, some non-rhabdomyosarcomas, soft tissue sarcomas, Wilms tumor, hepatoblastoma, germ cell tumors, and rarely adrenocortical carcinomas. So this is the definition for lung metastasis, which is the Euroma's definition for osteosarcoma, lung metastasis in osteosarcoma. So when you use a spiral CT scanning, the minimum criteria to describe a patient having a lung metastasis is whenever a single lesion is more than or equal to 1 centimeter, or when you have 3 or more lesions which are more than or equal to 5 millimeter in maximum diameter. So that will be classified as having certain pulmonary metastasis. So any lesion which are fewer or smaller in size will be considered as possible metastatic disease, and per protocol it will have a central review. So the significance of lung metastasis in osteosarcoma includes around 25% of 1 in 4 patients can have clinically detectable metastatic disease. Only 20% of the patients among them will remain disease-free. So at 5-year diagnosis, a patient with lung metastasis maximum can have a survival up to 30, maximum 40%. So lung as common to any other solid tumors. In osteosarcoma, it is the most common site of metastasis. Compared to beyond lung metastasis, bone on bone marrow metastasis, lung alone metastasis in the setting of osteosarcoma has a relatively better outcome. However, intensification of chemo, so addition of more and more chemo has not shown to clearly improve outcome in the setting of a osteosarcoma. So what COG tried was to add muramyl tripeptide and they randomized and seen in the setting of a metastatic OGS. There's some effect, however, it was not statistically significant. So moving to case, so we have a 12-year-old child with a left proximal tibia osteosarcoma. This child had NCCT thorax suggestive of bilateral multiple lung mets. So 2 nodules on each side. So bone scan had no evidence of bony metastasis. So my question to Dr. Girish is how in your clinics you prognosticate a child with lung-only metastatic OGS?
Thanks, Kala.
Yeah.
Yeah, go ahead.
So what are actually the points to consider while deciding on further treatment in a setting like this?
Yeah, thanks, Kala. So this is a very important point which I would like to emphasize, that unlike most other sarcomas, what we see in osteosarcoma, the lung metastasis, especially the resectability of lung metastasis, has a very significant impact on the long-term outcome. So in the sense, like in other sarcomas, you would actually give chemotherapy like a rhabdomyia or a Ewing sarcoma and the lung mets would disappear. The basic principle to remember is that in osteosarcoma, the chances of lung metastasis disappearing on neoadjuvant chemotherapy is extremely small. Our experience is less than 5% of osteosarcomas metastasis only would disappear. But if you look at various papers, I think they do publish 5 to 10%, but no more than that lung metastasis will disappear. In other words, if they're unresectable at diagnosis, the chances are very high that they will remain unresectable after chemotherapy. So the first point to consider is when you're prognosticating a child with lung-only metastasis is whether it is unilateral or bilateral. The number of mets, what you have, 4, 3, more than 3, more than 4, that is kind of the number which has been taken out depending on how much resectable it is. If it is obviously 4 in a single lobe, then it is better than having 4 in 2 different lobes. If it is 4 resected to one, is localized to one side, it's better than 4 being distributed across 2 sides. The second point is this location of the metastasis. You could have a single metastasis, but it's at the hilum and it is completely inoperable. Then again, that becomes a very difficult situation to cure. The third thing is tumor actually going through the pleura, causing, say, pleural effusion, hemorrhagic effusion. Again, that becomes a very difficult aspect to cure. So when we have a lung-only metastasis, the points we take into account are the number of metastasis, the laterality, whether it's unilateral or bilateral, the site of metastasis, where it is in the periphery or in the hilum, peripheral or more operable, and the last part is the pleural involvement. So this is very critical right in the beginning. And as I want to re-emphasize, many of us give a lot of chemotherapy for multiple pulmonary metastasis in osteosarcoma. We must refrain from doing that. If your thoracic surgeon upfront says this is not operable, it is very likely to remain inoperable, and the prognosis should be mentioned to the family. So these are the points which we need to strongly consider. It has to be a joint decision between us as well as the surgeon who is going to do the metastectomy. What are the chances of doing metastasis?
Yes, sir. Thank you, sir. So this is one French experience where they have noticed in a metastatic OGS, whenever they had greater than 8 metastasis, clearly the outcomes were less. We have decided to go ahead with a curative approach. What, as sir mentioned, surgical excision of all tumor site is the major independent prognostic factor. So this child, since the parents insisted on chemotherapy, the child was given a IAP chemotherapy. So, however, in the interim response assessment, she had somewhat a partial response. So I'd like to ask Dr. Shalini. So, what is the time point of consideration for metasectomy in the setting of OGS? And So pulmonary yeah, please, ma'am.
So a time point, actually, I think because adhering to the chemotherapy protocol is so very important. So we try to club it along with the primary surgery, especially if it is bilateral. And osteosarcoma again is one situation where we do try and do bilateral staged metastaectomies, and the one side may be the easier one, or it can also depend on which side you're going to do first. Suppose it's the primary is of the humerus, and so the same side chest wall may be difficult because the hand will be immobilized post-operatively for some time. So then we would do the opposite chest. We don't do bilateral thoracotomies simultaneously. Preferably we avoid it because then there's a chance of the patient going on ventilator. And so one side we definitely do around 11, 12 weeks of chemotherapy. And when we are planning the primary, if there's response, we usually do it along. And the second side, sometimes we do it at the end of the chemotherapy because we don't want to break the chemotherapy cycle. Every time there's a surgery in between, there's a break of almost a month, even if everything goes smoothly.
So what are all the indications? Where exactly we'll consider a pulmonary metastaectomy?
So when we are talking about osteosarcoma, if they are resectable, we definitely give it a try. And another thing I would like to say is many times the radiology says that there are 4 or 5 or say 7 lesions that they can see. And when we open up, we at least find double the number. And so that is why we try and avoid minimally invasive methods like VATS, especially in osteosarcoma. If it's a single metastasis, then probably yes, we can try for VATS. But in osteosarcoma, because they are sometimes they're very tiny nodules, and we need to palpate them. So that way, what I do usually is I do a mini thoracotomy, and I'm usually able to palpate and figure out how to. Other thing is when we are doing a VATS, then we definitely have to use staplers. And if there are multiple lesions and you use staplers for all of them, say 7, 8 or something, then there'll be a lot of loss of lung volume. So that is again something we don't want. And unless the contraindications will be that, as Dr. Girish mentioned, if it's a central tumor, which is not resectable, it's involving the hilum, the vessels, or one of the main bronchi, then definitely it is not resectable. Thankfully, most of the times in osteosarcoma, we do see pleural-based peripheral tumors. And again, the number, like once I opened and then there were like hundreds of lesions. And unless I can remove all of them, there's no point just going in, unless I want to just prove that, yes, this is metastaectomy. So if I should be able to remove all of them, and the location should be such, usually peripheral ones, we are able to do this.
Thank you, madam. So metastaectomy can be considered along with limb surgery or at the end of therapy. All these lesions, as madam mentioned, should be resected completely. We are treating with a curate point. As per uromass is when you use a MAP protocol, is between week 11 and 20. So thoracotomy with manual exploration of both the lung is strongly recommended. And thoracoscopic techniques, this also madam mentioned, is highly discouraged in view of lack of sensitivity and intraoperative tumor dissemination. So there are relative contraindications for metastaectomy when the patient has a poor performance status, inadequate pulmonary reserve, multiple metastases. The time to relapse was less than 12 months, central location, pleural infiltration, and poor response to line therapy. So the child, this child,
if I can just add to what Shalini said. So one of the approaches, and one side is looking doubtful that you'll be able to achieve surgical clearance, and the other side is looking clearly you can get a surgical clearance. You always approach the doubtful side first. If the doubtful side you cannot get surgical clearance at all, then you actually call it off. Because what you don't want to do is do metastaectomy at one side and totally be unable to do on the other side, because then it completely becomes palliative situation.
Yes. This child actually underwent primary wide local excision with endoprosthetic reconstruction. Post of his HPR had a 40% necrosis. So end of treatment, CT scan was done, which showed 2 subcentimetric nodules in the right lung. When we asked surgeon, they opined it is inoperable. My question to Dr. Girish is how to proceed with this child, and how will you do a surveillance in such scenario?
So did the surgeon say it's inoperable because it's too small,
Yes.
or it's not
Yeah.
operable?
No, it is very too small to operate.
So if it is at the, I mean, it has to be a discussion with the surgeon. If it is at the site of where the primary metastasis was, and there is a lesion still left there, then we would insist on the surgeon to go and try to get it out. But if it is not operable, or it was a sub-centimeter nodule which was not there and it is there and it's indeterminate, then in that case, it's completely fine to keep on surveillance. However, if it is not operable at all and it was at the site of metastasis, then we have to just wait and see, but the chances of recurrence are extremely high in this situation.
So should we do CT based surveillance or still usual X-ray based surveillance? What will you prefer in such situations?
So, yeah, so normally we would do a X-ray based surveillance, and in terms of survival, there is no advantage of doing a CT based survival or an X-ray based survival. But this situation is different. In this situation, if it is at the site of pulmonary metastasis, previous pulmonary metastasis, and you have 2 tiny nodules left there, you would want to pick them up early if they are increasing in size. So in that situation, I would probably do the initial CT scan at 3 or 6 months. And if they are remaining stable or gone away, then I would do a chest X-ray. But otherwise, routinely, a osteosarcoma who has reached pulmonary CR or doesn't have any pulmonary metastasis, chest X-ray surveillance is good enough. There is no benefit in terms of survival by doing CT scan surveillance.
Yes, sir. Thank you. So moving on to the second case. So we had a 13-year-old male child with the left distal femur, non-metastatic OGS upfront. As he completed his treatment, he had a treatment-free interval of 12 months. So he presented now with lung-only relapse. He had a right lung single nodule. So in this setting, what is the role of metasectomy? Dr. Shalini ma'am.
So looking at this particular CT scan, it looks more like a central, quite a large, I think more than a centimeter large lesion. And I'll have to look at more scans to see whether it will be easily resectable. To me, it looks difficult to resect. In that case, in the, with the background of osteogenic sarcoma, sometimes we may need to just document it's not some granulomatous lesion, not TB, nothing. And we may just need to do a biopsy, like image-guided biopsy also, in case we are not sure that this is a lung met, because it's a single one. But looking from this single image, it doesn't look operable to me right now.
Sure. So my question to Dr. Girish sir is there any role of chemotherapy in this setting?
So the short answer to your question is there is no role for chemotherapy in a relapsed osteosarcoma. There is no clear-cut evidence that chemotherapy plays a role, or any of the newer agents which have come also play a definitive role in survival in a relapsed osteosarcoma. However, there may be some benefit in patients who relapse late. So clearly, patients who relapse 2 years, 24 months, compared to 12, more than 24 months later compared to less than 24 months do much better, as in about 20-30% cure rate if surgically resectable, compared to those who are less than 24 months. There is a tendency with no strong evidence to give chemotherapy when there is a late relapse, thinking that there may be some level of chemo, it may be chemosensitive. But for early relapses, in a 12 months There is no role. I would do only surgical metastectomy and just wait and watch.
So, moving on to the next topic, which is Ewing sarcoma. So, the definition for pulmonary metastasis is same between Ewing and COG, which is when you have one pulmonary nodule which is more than 1 centimeter, or more than one nodule which is more than 0.5 centimeter. This is considered definitive evidence of pulmonary metastasis. However, when you have a solitary nodule which is between 0.5 to 1 centimeter, or when you have multiple nodules which is 0.3 to 0.5 centimeter, which are actually questionable, which needs biopsy proof for confirmation for lung metastasis. However, you have a solitary nodule which is less than 0.5. You have several nodules, however, it is less than 0.0 centimeter. Generally, are not considered as evidence of lung metastasis, setting of a Ewing sarcoma. So, similar to osteosarcoma, around 25% of the patients have metastasis at diagnosis. Lung metastasis is the most common, and however, a patient with lung alone metastasis in the setting of a Ewing sarcoma have a relatively better outcome, up to 50%. And here we can actually use bilateral lung irradiation. So, moving on to the first case. So, we had a 2-year-old female child who had a pelvic Ewing sarcoma with right-sided lung metastasis. She had actually a single nodule. So, my question to Dr. Girish, sir, is that how will you prognosticate this child?
So this is a child with only lung-only metastasis of an Ewing sarcoma. So the tumor is large tumor in the pelvis. So may or may not be surgically resected. You may end up doing definitive radiotherapy to the primary side. So axial tumors, which we cannot operate and we end up doing radiotherapy, do have a slightly lower outcome in this situation anyway. On top of it, you now got a pulmonary metastasis. So it is a tumor which has got not a very high risk, but a moderate risk of relapse. So we would say it would be about 40% long-term cure rate at best in this situation. The primary axial with an axial tumor or a midline tumor with a pulmonary metastasis, maybe about 40%.
So, what are all the chemotherapy options in an Indian scenario? How we should proceed?
So it is standard chemotherapy what we would use. The VAC-I is the standard protocol which many people are using in the country very successfully. So I would encourage to do that. The EFT 2001, which has been published as well, has also got a fairly good outcome in pulmonary metastasis, Ewing sarcoma. So both of this you would do. The Ewing's protocol, the original one with the wide chemotherapy, is just too toxic in an Indian setting, and hence I would personally not recommend doing that 6 cycles of wide chemotherapy, and it is quite intensive compared to others. Those are the options which are there. And to your question of role of high dose chemotherapy with a stem cell transplant, I don't think there is any role at all to do in this situation. And that has also been proven in a randomized trial, as I'm sure all of you know.
Yes. So this child received a weekly VAC-I protocol. So her interim response assessment done after 9 weeks, her lung mets were in CR. So I would like to invite Dr. Srinivas. Can we avoid lung RT in this child?
Thank you, Dr. Kalashekar. I don't think we can avoid whole lung radiation, especially if there is some kind of response in the primary and the child is suitable for a radical treatment. I would definitely be considering whole lung radiation therapy for this child, irrespective of the response, unless obviously if I see a progression, then that's a different story. But if it is a response, a partial response or a complete response, which can happen in these patients, especially with respect to lung, what I meant, there definitely we should consider whole lung radiation therapy.
So in your clinical practice, what is the dose of lung RT used in the setting of Ewing's sarcoma?
So a variety of dose fractionation has been used across studies ranging from 12 to 21 gray. But the standard which we usually use is about 15 gray. There is some data to suggest that younger patients could receive slightly lesser doses of radiation, such as 12 gray. But by and large, we would consider 15 gray. As you know, that Ewing sarcomas are, in fact, some of the rare situations where there is evidence for dose escalation as well. Of course, we are not talking about the primary tumor, but the prophylactic whole lung irradiation, wherein 15 gray is what is usually recommended for most of these children.
Yeah. So when exactly will you do a whole lung RT along with the local RT or at the end of therapy? What is your practice?
So that is also a little bit, kind of controversial across different studies. Different timing of radiation has been used. One could use it along with radiation to the primary. The only issue is because along with primary radiation, a lot of chemotherapy is concurrent. Therefore, it is sometimes challenging to give such large fields along with concurrent chemoradiation. Therefore, we usually do at the end of treatment, the whole lung radiation. So we go ahead with the primary radiation at the time of week 11 to 13, but consider whole lung irradiation at the end of treatment after we finish the chemotherapy cycles. Although there are some who consider during radiation also, of course, the dose is significantly reduced. And but as I said, I would not prefer that in usual situations. I would not like to reduce the intensity of chemotherapy, which is extremely important. And as far as possible, we would like to maintain the dose intensity during radiation therapy as well. And therefore, I would give whole lung irradiation at the end of treatment.
Is there any long-term concerns with whole lung RT?
Well, there are long-term concerns with everything in Ewing's, right from surgery and chemotherapy as well, and therefore radiation also has definite concerns, especially when such large fields are used in adolescent boys and girls, especially with respect to cardiac irradiation. And therefore, there is a lot of emphasis on using modern techniques, conformal techniques such as IMRT and VMAT, or even protons to reduce the dose to the heart significantly. There are studies which have reported, long-term studies which have reported up to 2% pneumonitis risk, that is inflammation of the lung, chronic inflammation of the lung, chronic pneumonitis. But those are usually the grade 3 pneumonitis are extremely rare. Not with the modern chemotherapy practice, modern chemotherapy protocols, and with radiation of 15 gray, usually we never encounter that problem. But cardiac risk is an important factor, especially in these children who have received a lot of anthracyclines as well, along with radiation. So that is a concern. Cardiac toxicity is a concern. But I think there is a definite evidence to suggest that there is a benefit in these children who receive whole lung radiation. Therefore, we would do it irrespective.
Yeah, thank you. Dr. Shalini, is there any role of pulmonary metastectomy in the setting of Ewing's?
In this particular case, anyways, there's CR, so there is no role as such. But if sometimes there's only a single metastasis, and it is easily resectable, and we are going in for the surgery of the primary as well, which again is not the case in this particular patient, then we do. But because we have radiation as a backup, so we do not very aggressive for doing metastectomy in Ewing's, unlike osteosarcoma.
Yes. One question to Dr. Srinivas. Suppose you have a partial response. So so surgeons are telling it is not amenable for surgery. Will you do a whole lung RT with a focal boost?
We can do it, but see, if that's why we are doing the lung RT at the end of treatment. Even at the end of treatment, if there is a residual disease, it's definitely not a good news for the patient and for us to have that situation. Nevertheless, in those situations, I would also consider and talk to my colleagues in the surgery to consider pulmonary metastatectomy even at that stage, if there is a partial response, good partial response. But yes, in situations, very tiny residual disease where you are able to see metastases after the end of the chemotherapy, there is a provision to give a little bit of boost to a higher dose to the metastases, along with 15 gray prophylactic whole lung irradiation. It is possible to do it. But in most situations, when I see a MET, we would definitely think of a metastatectomy.
Yes, thank you. So to summarize, we have to give whole lung RT irrespective of response in the setting of Ewing sarcoma, and the doses, as mentioned by Dr. Srinivas, is between 12 to 15 gray. So radiation doses are generally modulated based on the amount of lung to be irradiated and based on pulmonary function. So moving on to the next sarcoma, which is rhabdomyosarcoma. Lung metastases are the most common site of metastatic disease in the setting of rhabdomyosarcoma. So it usually presents in around 6% of all newly diagnosed RMS cases. So among stage 4 patients, close to 50% of the patient will have lung metastasis. So isolated lung metastasis similar to Ewing's as a good outcome even in the setting of a rhabdomyosarcoma. So the first case is a 5-year-old male child who presented with a parameningeal ARMS with isolated right lung metastasis. So, however, his fusion status was negative. So, my question to Dr. Girish, sir, so how will you risk stratify and prognosticate this patient?
So, so this is stage 4 disease, but the age is less. It's a fusion negative rhabdomyosarcoma. So in that situation, the prognosis is not as bad as a fusion positive rhabdomyosarcoma, or as somebody who is a much older child, say more than 10, 11 years of age. So in this case, we would classify this as intermediate risk, but for practical purpose, the treatment is pretty much the same in this situation. Whether it is fusion positive or fusion negative, treatment would pretty much be the same, except that the prognosis would be different. So we would classify this as intermediate risk on technicality.
Yes. So any chemotherapy options?
So the best chemotherapy option is the same, which we all know. It's vincristine, actinomycin, and cyclophosphamide. And we would do the same. There is little advantage of doing anything different other than these 3 drugs.
Yes.
And a good dose of cyclophosphamide.
Yeah. Actually, this child, we have given VAC chemotherapy with a cyclophosphamide dose of 1.5 gram per meter square per cycle, which is our institutional protocol. Post 9 weeks, NCCT thorax was suggestive of partial response. So, how will you proceed in your clinical practice in a scenario like this? Question to Dr. Girish.
So, there is little, if it is responding, I would carry on the chemotherapy and reassess again at 3 cycles later. If it has completely disappeared, there's nothing to do. If it has not disappeared, probably at 6 cycles, we would plan, at some time we would plan a pulmonary metastectomy. That is what would be the approach. We would not plan anything else other than continuing chemotherapy, which is responding and disappears, do nothing. If it persists, do pulmonary metastectomy, and that's where we would stop and complete rest of the adjuvant chemotherapy. And of course, radiotherapy to the primary site as well.
So this child actually proceeded with chemotherapy, and post 15 weeks, she had a complete response. So what is the next step in the case of the lung metastasis? Is there a role of lung RT, Dr. Srinivas?
Lung RT is definitely a bit more controversial in RMS compared to Ewing's, where it is considered standard of care. But having said that, the initial CWS studies, later on European soft tissue sarcoma MTS 98 study, all have suggested that there is a role for irradiation of all the metastatic sites, or one or all the metastatic sites, whenever it is feasible. And there also seems to be a benefit in whole lung irradiation as well. We would do it again, as I mentioned, for Ewing's. We would do it similar doses of radiation. I would consider lung radiation in this particular situation where when we radiate the primary, definitely we should consider for lung irradiation as well, especially if there is a complete response.
Thank you, Dr. Srinivas. So actually the literature is very controversial. If you see the North American data, so where clearly there is no difference in outcome whether you give whole lung RT or no lung RT in the setting of an isolated lung only metastatic patients. However,
so Dr. Kalashekar, regarding this COG study, there are a lot of some editorials written about this particular study which has been mentioned. It has to be seen in the context that in this study, the adjustment to the timing of radiation has not been looked into, as well as something called landmark analysis, which is a statistical method that has not been done in this particular study. Therefore, there are some limitations, and you can see the numbers are all small. A small alteration in the statistical methodology can alter the results in a big way, and therefore I mean, of course it is controversial. I agree to your statement, earlier statement, no doubt about it, and that's what I mentioned as well. But I think this particular study which you have shown has some limitations.
Yeah. So, however, in the European EPSSG setting, in this particular scenario, they have clearly seen a EFS benefit. However, it is practically, you see, a patient who is responding to chemotherapy, we generally tend to avoid a lung RT. If it is persisting, maybe you can consider a whole lung RT. So, Dr. Girish, sir, you want to comment on this?
Yeah, sorry. So so there's no clear data definitely for giving lung radiation, especially in those situations where the nodules have disappeared. But we, as a policy, if the lung nodules are there and they're disappeared, we will go ahead and do whole lung RT. But we have no strong evidence to support that that is a better strategy than otherwise. But that's what we would do. But that's not what we can strongly recommend that is the way forward either.
Yes. So moving on to the next sarcoma, which is NRSTS. So we had a case of 10-year-old child who had presented with the left distal thigh synovial sarcoma. NCCT thorax was suggestive of bilateral lung nodule, 2 nodules in each lung. So how to proceed with this case? So
here because it's a synovial sarcoma, so because it's a synovial sarcoma, there is a scope for giving chemotherapy and seeing if there is a response. So in this situation, I mean, it is high-risk disease. They are obviously not as chemosensitive as Ewing sarcoma or rhabdomyosarcoma, but they do have chemotherapy has some. I mean, these tumors are sensitive to ifosfamide doxorubicin to some extent. Hence, that's what we would do first. Give the ifosfamide doxorubicin first, and since only lung metastasis and no other metastasis, we would give 2 or 3 cycles and assess what happens. So that would be our approach. We would give ifosfamide doxorubicin and then reassess after 2 or 3 cycles. Subsequent to that, we would approach the primary, I mean, if the nodules are not disappeared, they're operable, we would operate the lung nodules as well as obviously do the primary tumor surgery and do radiation to the primary tumor. We generally in synovial sarcoma have not done, if you operated any radiotherapy to the lungs.
Yes. So in the COG approach, actually this metastatic tumors with high-grade metastatic NRSTS. So we have to, if we are resecting, grossly resected tumors will require adjuvant chemo plus RT. Otherwise, we have to proceed with neoadjuvant chemotherapy. We have to do surgical resection of the metastasis if it is persisting and local. This child actually, we gave 3 cycles of ifosfamide doxorubicin. So response assessment, this CT scan was suggestive of partial response with reduction in size of the nodules. So I would like to ask Dr. Shalini, what is the role of metasectomy at this point?
Yeah, so since there is a partial response and looking at the images, you said, actually there were no images, but you said there are 2 nodules on both sides. So that means probably we'll be able to do one side. So again, I think we can wait till the time of local control if we are going ahead with that. And if at that time it's feasible, we should, 2 nodules, I think we should try and go and remove them.
Yes.
And of course, we have to see maybe of the other side, we'll have to decide. So it's a little tricky here because as Dr. Girish said, they're not as chemosensitive as the other sarcomas. And so surgery has a very important role in non-rhabdo sarcomas, and same way radiation also.
Yes. Dr. Srinivas, is there any role of lung RT, or when you will consider a lung RT in the settings?
So in this setting, definitely there's no role for lung RT. I mean, in synchronous metastatic disease, definitely lung RT, maybe as a palliative situation, we would give, but not in a radical setting. In metachronous, when there's a long disease-free interval, maybe in certain cases when the surgeon says that it is unresectable or it's in the central location, difficult location, possibly an SPRT could be considered. But those are very rare situations. Otherwise, I don't see a role for lung RT. A role for primary, of course, as Dr. Girish mentioned, in situations where we resect the primary, is resect the lung metastasis as well. There is a role for adjuvant radiation to the local site.
So this is the COG approach for lung metastasis in NRSTS. So if you have a CR post neoadjuvant chemotherapy, there is no role for RT. So if you have a persisting nodule, you can try metasectomy, and if CR is achieved with metasectomy, there is no role for RT. Suppose if you are not able to do a metasectomy, or you have done only a biopsy, and you can consider a focal RT.
These days, that is extremely uncommon.
Yeah.
Good surgeons and good surgical techniques. It's very rare that small operable lesions have margins positive.
Yes. So thank you. So let's move to the next tumor, which is Wilms. So if you're a patient with lung mets, we consider that patient as stage 4. So close to 15% of the patients present with stage 4 Wilms tumor, lung being the most common site. The definition between SIOP and COG is almost the same. Any nodule which is more than or equal to 3 millimeter and the transverse diameter will be considered as lung mets. However, the treatment approach varies between COG and SIOP. So in the COG approach, we start with the 3-drug chemotherapy and reassessment is done at 6 weeks. The patient has lung mets, which is in CR, and if the patient don't have any LOH, 1P or 16Q, current studies, what they did was they tried to avoid a whole lung RT. However, the EFS was lower, especially in patients with 1Q gain. And if the patient had lung mets which is in PR, or the patient have a LOH, irrespective of response, they gave whole lung RT with escalation of intensification of chemotherapy by adding cyclophosphamide and etoposide, where the EFS was better. The cumulative dose of doxorubicin in the COG approach is only 150 mg per meter square. However, in the SIOP approach, they also start with the 3-drug chemotherapy. Response assessment is done at 6 weeks. If the lung mets are in CR, they avoid RT, and lung mets in PR, they try to do a metasectomy. If metasectomy was done, and they avoid whole lung RT. If metasectomy is not feasible, the intensification of chemotherapy will be done. The reassessment will be done at 9 weeks. And if metasectomy is possible at that point with intensification of chemo, or it's completely disappearing, so they avoid RT. If it is persisting, then whole lung RT is considered. However, the cumulative dose of doxorubicin in a SIOP approach is 300 mg per meter. So moving on to the case. So we had a 3-year-old male child with a right-sided renal mass with bilateral lung metastasis, which were multiple. So child underwent an upfront surgery. So post-op HPR was suggestive of a favorable histology films with margin positivity. So LOH status was not done. So my question to Dr. Giri sir, so how will you proceed with this child?
So exactly same as you said. So it's a local stage 3 disease because margins are positive, and you also have pulmonary metastasis. So we would start off with 3-drug chemotherapy, vincristine, actinomycin, and doxorubicin, and then subsequently assess what happened to the lung mets and do radiation both to the flank as well as in this situation, even if they disappear, because we don't know the other biological features, I would recommend that we actually do lung RT as well.
What is the ideal
Srinivas,
time?
what do you think?
Yeah.
Now, what does Srinivas think about
Dr.
lung RT?
Srinivas.
Sorry, I didn't
So
see the
basically, it is
case.
a stage 3 Wilms tumor locally with
Okay.
bilateral lung mets. It's a favorable histology.
Favorable histology, Wilms with margin positive.
Upfront surgery.
So definitely flank RT is required, and there is lung mets also. And at the end of treatment, if the lung mets are visible, then definitely lung RT should be considered.
Yeah.
If the lung mets are not visible on the scan, then you don't need to consider whole lung radiation.
So you will avoid lung RT if there is a complete response.
Yes, I would avoid completely. Dr. Girish, you would consider.
So what I was telling was, see, because if it put things in perspective here, so we got a stage 3 disease and we got in the local stage 3, plus you got pulmonary metastasis. That means you're going to use 3-drug chemotherapy. So we are starting off in a high risk situation already, where it is metastatic disease plus stage 3. And we don't know the LOH, though let us assume we are working in a situation where that LOH is not there, because it's not there anywhere in the country. We are not doing it, or at least I'm not aware anybody does it routinely. So in this situation, a relapse is very difficult to salvage because you have used 3 drugs chemotherapy and you're starting off with stage 4 disease. So after using 3 drugs chemotherapy, if somebody relapses, the chances of cure are extremely small. So I think here we must try whatever we can to avoid the relapse. So in that situation, we should do the flank RT, as Srinivas said.
For sure.
But my take would be that at 6 weeks of chemotherapy after 3 drugs, if the lung mets have disappeared, I would still do the lung RT in this situation. Only because we do not have better information on the biology of the disease. And if relapse occurs, this is a very difficult situation to salvage. And from what we discussed in the previous case, the whole lung RT, if the nodules have disappeared, the risk benefit, I think that's one of the safer radiation in this situation to do, the whole lung RT, rather than having a relapse. I think the risk benefit would support in this situation to do whole lung RT. That's my take on this.
Yes. So, Dr. Srinivas, you have decided, suppose we can have a scenario like this. You have decided to give a whole lung RT. What will be the ideal time point in this case?
At the time of, after the completion of chemo, usually we give it after completion of chemotherapy, but it, because if the decision regarding whole lung RT is already taken during the, after the, basically we will assess after the surgery, probably I would give whole lung RT after the end of the chemotherapy.
So you would have given a flank RT in this child. There overlapping radiation field a concern being?
Yeah, it is a concern, but not usually a concern if it is in the same, treated in the same center. If we have the fields of irradiation, we can actually make sure that we don't overlap significantly. There is a small concern because, but the dose we do is very, very little, it's 12 gray. So I don't think it is a huge issue, especially if it is done in the same center. and we have complete understanding of what was irradiated as part of the flank irradiation. It is not a major concern. It needs to be, we need to be careful of it and cognizant of it, but it's not a major concern. It can be done.
Yes. So,
So I think, can I just say something? I think the umbrella protocol says that we should do it simultaneously, but even that sometimes is difficult whenever we've tried on a child, especially on the right side, giving the lung RT as well as flank RT. The patient had a lot of hepatotoxicity despite doing it, especially when we did simultaneously and with concurrent chemotherapy, which was upgraded because the lung mets were not resectable.
So if that's why I would not combine it along with, therefore, I would usually, we wouldn't do it in a stage 3 case, say stage 3 sitting when we have a complete response. Usually, unless there is a specific case where on as per the discussion, as Dr. Girish mentioned, that on a case-to-case basis, you consider for whole lung irradiation. In those patients where whole lung irradiation is considered, I think 12 gray along with flank RT, even on the right side, it's not a huge concern. With IMRT, we are able to spare some portion of the liver, definitely. Along with whole lung irradiation, there will be some portion of the liver being irradiated. With IMRT, I don't think it is a concern. Hepatotoxicity.
actually, we had a lot of it. This is actually a case in our MDT discussion when the point of lung irradiation and overlapping, a lot of concerns were there. So, COG, what they do is they start with the chemotherapy and they give flank RT also. Response assessment will be done at 6 weeks. And if it is lung RT is given, it will be based on the response in the arranged studies.
Based on the response, meaning that there is a complete response, we avoid RT.
If LOH is not there, they will avoid. If LOH is there, and irrespective of response, or if there is a partial response, they give lung RT. As per arranged studies. Shall we proceed with the next case? So this is a case of a 5-year-old child who was stage 3 favorable histology Wilms tumor, who upfront received 3-drug chemotherapy with flank RT of 10.8 gray. After a treatment-free interval of 12 months, he had a lung-only relapse. So, question to Dr. Girish, how will you prognosticate this patient?
So there's a 5-year-old, right, stage 3, so has received flank RT and received 3-drug chemotherapy. And the duration is about 12 months and it's lung-only relapse. Since we have given 3 drugs chemotherapy, this is a high-risk relapse, what we are dealing with. So in this situation, prognosis with using carboetapocide, cycloetapocide combinations may be about 40% outcome, along with plus or minus, radiation plus or minus surgery, whatever we do for the lung.
So, which chemotherapy regimen which you have already mentioned? So,
yeah.
The role of upfront metastasis in this child, Dr. Shalini.
Wilms is a very, very chemosensitive disease. So I don't think I would like to. It's quite a large lesion also. Unless radiologically there was a doubt about it being Wilms and it being something else. So radiologically it does look like a clear-cut metastatic deposit. If you want to document, you could do a biopsy. But I think I'd definitely go for chemotherapy first. And if it persists, then we could do it a single lesion. We could do a metastectomy.
So Dr. Srinivas, what is the role of lung RT in this setting? Who has received upfront lung RT with 3-drug chemo? How will you, as a radiation oncologist, what is the role of lung RT? Hello,
I
Dr.
think
Shields.
we just lost him. He maybe just rejoining in a minute.
Yeah. Should we wait?
You can probably proceed with the next question and then get back to it.
Yeah. So this child actually underwent a upfront metastasis. So currently is on cyclo-etopo alternating with carbo-etoposide and plan for whole lung RT up to 4 cycles. So moving on to the next case, the next tumor, which is hepatoblastoma. So around 20% of the patients with hepatoblastoma has presents with lung metastasis. Generally, a patient with the lung metastasis in the setting of a hepatoblastoma has a poor 5-year event-free survival. CT scan remains the gold standard to detect lung metastasis. So definition, which is commonly used, is when you have a single nodule which is more than 1 centimeter or several nodules are there with at least one more than 5 millimeter, we consider as lung mets in the setting of hepatoblastoma. So moving on to the case, it's a 6-year-old girl that was diagnosed with a high-risk hepatoblastoma, her pretext being 3, and she had a baseline rupture.
ఏంట్రా ఏసీ బాగా పనిచేస్తుంది ఏం చేసావు ఏమన్నా కుండ లాంటిది పెట్టావు పైన ఎంత బాగా పనిచేస్తుంది అనుకోలేదే
So this child had a bilateral multiple metastasis. Her baseline serum AFP was 90,000. So which protocol should we consider in this setting? Child who is pretext 3 with baseline rupture, bilateral multiple metastasis. Dr. Girish.
Yeah, so difficult call to take, man. It's a very contextual question. If you do Cypel 4, you must be ready to face that you'll have far more cisplatin autotoxicity in the Cypel 4 high risk arm. And at the same time, you do not have any of the autoprotectants which are proven to be useful in this situation. So I would personally go with Superplado and go and treat with, it's a high risk disease, whatever. I would personally go with Superplado and treat with Superplado is what I would actually do in this situation. But again, as I said, it depends on, it is a trade-off between having autotoxicity versus better response rate or slightly lesser recurrence rate. But I would go with Superplado because of the high risk of autotoxicity in this situation.
So does intensification of chemotherapy increases the chance of response?
So Cypel 4 is supposed to be better in that situation, but overall, as I said, it's a trade-off between having one toxicity at the cost of some slightly better improved response or some improved response.
So what will be the time point of lung response assessment in this?
So again, this is a very chemosensitive tumor. The need to do metastatectomy in hepatoblastoma is far less than in sarcomas, especially osteo or synovial sarcomas. So most of the time, the lung metastasis disappears and it is rare for us to do it. So in this situation, after 4 cycles, anyway, you would assess for primary tumor surgery. At that time, you can see the lung as well. And if it is showing a good response or it is disappeared, then obviously you would not do anything. If it's showing a good response, about showing a partial response and nodule is there, I would still continue the chemotherapy and do metastaectomy at the end. All this depends on the response in AFP you're having as well. Provided the AFP is also responding and the nodules is also decreasing in size, then in that case, you can continue till the end and do the metastaectomy at the end, if it is still persisting.
So, so as Sir mentioned, the toxicity is actually a major concern when you use Cypel 4 with weekly cisplatin. However, chemointensification has clearly shown to improve response and both lung and at the local resection. So the time point of response assessment generally after 2 to 4 cycles of neoadjuvant chemotherapy. This child received actually a Cypel 4. Her response assessment after 4 cycles, she actually had a complete response. So, Dr. Shalini, when will be the surgical metasectomy to be considered if you have a partial response? And what will be the points to note, especially in the setting of a metasectomy for hepatoblast?
So again, it will all depend on the response to treatment and the drop in the serum AFP levels, whether the disease overall is responding or not. And as you said, this is pretext 3. So we need to see whether the primary tumor is resectable, and what is the suppose this child is going for extreme resection, or for some reason maybe the veins are involved, or portal vein is involved, or all 3 hepatic veins are involved. Suppose this child needs to go for liver transplant. In those situations, we would sometimes want to do the metastectomy of the lung first, especially liver transplant. We would not go for liver transplant without doing a lung metastectomy. With the presence of a metastatic disease, that's a contraindication for liver transplant. Otherwise, we can also wait. If it is all responding, we can do the primary surgery and we can continue the chemotherapy, and at the end of treatment, whatever is persisting, we can go ahead. Again, also depends on the number of lesions, and as Dr. Girish said, most of them will respond quite nicely.
So this is a literature on lung mets. So far, 434 cases has been reported. So with chemo, close to 45% of the patients had a complete response. So 1 in 5 patients actually required a sectomy. So the timing was in the literature was before primary tumor surgery or after or simultaneously. Practically, we generally wait for chemo response and decide for metasectomy if it is persisting after completion of chemotherapy. So, so usually you will do a response assessment after 2 to 4 cycles of neoadjuvant chemotherapy. The lung mets are in CR, we can proceed with the liver resection followed by completion of adjuvant chemotherapy. Suppose the lung met is in PR, partial response, can proceed with the liver resection and pulmonary metasectomy and complete the adjuvant chemo, or you can do the liver resection and complete the adjuvant chemotherapy and reassess the lung at the end. If with adjuvant chemo, the lung is in CR, you can complete chemotherapy. So, and the tumor markers also should fall. And if it is persisting at the end of chemotherapy, if you can consider a metasectomy. So moving on to the next.
Kala, if I may just, go back to the previous slide. Yeah, go ahead, Shalini. Please go ahead.
And I just wanted to say a word about simultaneous lung metastectomy in hepatoblastoma. Sometimes that can be very tricky because the liver surgery itself will be a little longish surgery with some expected blood loss, and they're mostly hepatoblastoma children are infants. So doing a simultaneous liver and lung surgery at the same go can be challenging in terms of not just doing the surgery, in terms of post-operative care.
Yeah, so for the options you have put, I think they cannot be one or the other. It has to be viewed in the context of how the tumor is responding. So if you are having an AFP dropping very well, it continues to have a log reduction and dropping rapidly, then your option of doing liver resection, which is option 2, adjuvant chemotherapy, and then reassessing at maybe after 6 cycles or end of treatment, doing for reassess for lung mets is okay. But suppose the AFP has plateaued and the lung nodules are persisting, then I would do the surgical component of the lungs as early as possible, as much as it's safely possible to do, as Shalini explained. So I think the decision should not be, option should not be 1 or 2. So 1 is you would do that if AFP response is poor or it's plateaued. 2 would be the AFP response is very good. Then in that case, it is safer to wait till the end. I think that dynamics of AFP response should be built into this decision making.
Yes. Yeah.
Agree.
So moving on to the next tumor, which is germ cell tumor. So in germ cell tumor, so the risk stratification. So basically, any germ cell tumor which is stage 1, we can actually classify it as low risk. And any patient who has a stage 3 or stage 4 extragonadal, we can classify it as high risk. Anything rest of the tumors generally is considered as intermediate risk. So the low risk patients generally we observe, and the outcomes, the survival is more than post surgery we observe, and the survival is more than 95%. So intermediate risk patients and the high risk patients, the chemotherapy is almost the same, which is if we use PEB cycle, which is 4 cycles. For JEB we are using, we give 4 cycles plus 2 cycles till the AFP response is complete. So Germans use another regimen called as PEI. So so intermediate and high risk, basically the chemo regimens and the number of cycles are almost the same. Why we are actually risk stratifying is based for the basically for prognostication. So the approach to lung metastasis in germ cell tumor generally being, we give 4 cycles of PEP and reassess the lung mets at the end of 4 cycles. So the lung is in CR generally, and the AFP is normalized, and the local is in remission. We continue to follow up the patient. Suppose if the lung is in PR at the end of chemotherapy, we can consider metasectomy. So and Dr. Shalini, you want to add?
So I think again in germ cell tumors, the response to chemotherapy and the fall log reduction of AFP, again we can use that as a helping guide to guide us whether we need to do metastectomy or we can just do a close follow up. So definitely, if the AFP is normal and even if the CT is showing something small at the end, we would just follow it up closely. But occasionally, yes, if there's a need, especially if the AFP is plateaued, we can do a metastectomy in germ cell tumor as well, provided the numbers are small and it's feasible surgically.
Yeah. So so when the North American and European data were combined, there are pretty much there are 3 or 4 poor prognostic factors which are identified, which include age more than 11, more than or equal to 11 years, and stage 4 ovary, and stage 3 and 4 extragonadal. So based using these 3 prognostic factors, the current magic risk stratification is being done. So my question to Dr. Girish, how in an Indian scenario, especially in a high risk setting, how should we use this magic risk stratification?
I'm sorry to interrupt, but we just have maybe another couple of minutes and then we will take the questions in the chat box and then wind up. Thank you.
Sure. So just quickly, not a huge amount yet, what it means in an Indian setting. For the take-home message from the new magic risk stratification is the more than 11 years old or the older patients whom we are seeing had a tendency to do better with cisplatin rather than carboplatin and with 3 doses of bleomycin. So right now we do not know whether carboplatin can replace the cisplatin in that situation, and that's what it means to us at the moment. So more than 11, as you reach the second decade, doing 3 doses of bleomycin with cisplatin may be a better one, but we will know that after the trial is over. Otherwise, as yet, it doesn't mean a huge thing yet.
So this is the magic stratification, which is basically an ongoing trial. So where in a poor prognostic setting, they are actually randomizing between BEP versus accelerated BEP. So with which we are coming to the end of this session. Over to you, Dr. Vasu.
So thank you very much, Kalashikar, for the excellent presentation. And I think in the 1 hour that you had actually covered most of the common pediatric solid tumors and common scenarios that we see. I would request Dr. Shruti to kindly go through the questions which are put up in the chat box.
Thank you, Vasudev, and thank you, Kalashekar. I think it was a brilliant presentation, and it was a quick wrap up of all the tumors that we deal with right? So I think the very first question comes from Dr. Warrior, where he's asked what's the role of artificial intelligence in the diagnosis of lung mets. So Dr. Girish, over to you, please.
Yeah, so sir, as I briefly put up there, so there is a lot of studies going on to look at to characterize the lung mets better using artificial intelligence. In fact, one of the studies was presented yesterday only in Tata Memorial Hospital on a meeting for lung mets as well. So it is being studied, and we do think it will be an adjunct to what we do in the future. But there are multiple studies going on.
So just to add on to that, a lot of time we get patients who've had a CT scan done outside, but the cut sections are really wide. So would you perform a repeat CT in that scenario, or you just try to get away because, again, radiation becomes a concern for smaller children?
Sorry, repeat again, Shruti.
So a lot of times, children come to us with CT scans which have been done outside, and the sections are not really thin sections. They're like wide sections, 1 centimeter apart or so. So would you repeat a CT in such a scenario? Because, in a young child already receiving, a lot of chemo radiation, repeating a CT sometimes becomes a concern.
So if it is lungs are clear on the CT scan, probably I would not. If there are any doubts that there are small nodules is there and 1 centimeter might have missed multiple nodules which are less than 1 centimeter, only then. So, but I don't know, I want others to opine as well. We generally would not repeat just because it's a 1 centimeter cuts.
Basically, when you do a PET CT, the sections may be little larger, and you have a doubtful lesion, maybe you can do a CT thorax per se. Otherwise.
So it is important, I think, to do a HRCT thorax wherever possible in the first instance itself. So whenever we image children, I think better to do a good study, a robust study, as much as possible. Of course, it's not in our hands most of the times, but wherever possible, whenever we image children, whenever we are radiating those young lungs, even with a low dose CT, it's better to do a proper study so that we get every information possible.
Thank you, sir, for adding to that. So what Dr. Warrior has asked again is, how often have you noted these lesions to be granulomas, especially when a child has a CVL instead of tumors? Dr. Shalini, I think if you can take that question.
I would say in my experience, it's been very less. In the outset where we have an underlying solid tumor of childhood and we get a well-defined lung lesion, most of the times it is metastatic. But again, I think the discussion with the radiologist is very important because sometimes, and again, the quality of images. So sometimes because, we have tuberculosis is quite rampant, and that could be an overlay of tuberculosis as well.
Great. And ma'am, the other question is also for you. What time would you prefer to do a metastatectomy in a child with OGS? I think you've answered it, but just to reiterate once again, what would be the ideal timing to do a metastatic resection?
So we try to club it with the primary resection. If it is just a single side, we would definitely like to do it. Otherwise, we had a discussion on which side to do first and which side later. And if it's both sides, then we do a staged one. One side at the time of surgery and maybe the other side at the end of treatment to keep the continuity of the chemotherapy.
Right. So I think the next couple of questions are regarding chemotherapy and radiation. So there are, questions like chemotherapy, should it be continued during RT, whether local or whole lung for Ewing's? If yes, which one to be continued? And if not, then how long it has to be discontinued? How many days it has to be discontinued? So Girish, over to you again.
Yeah. So first thing is that we can safely give concurrent chemotherapy with radiotherapy, except that remember that when we are doing that, there are some drugs which act as radiosensitizers and also cause radiation recall. So actinomycin D and doxorubicin are the drugs which we commonly use, which we avoid during the radiation. And post-radiation, generally within the first 2 weeks, we do not, especially actinomycin D, for the reason that the radiation recall is much higher with actinomycin D than with doxorubicin. So in that situation, we would wait at least 2 weeks. Empirically, people give after 2 weeks first dose 50%. If nothing happens, then next dose go up to full dose. But there's no hard and fast rule. I think there are many people who would give after 15 days full dose as well directly. But that's the strategy which needs to be followed. Definitely avoid doxorubicin and actinomycin D during the radiation.
Right. And Dr. Shalini, I think we've discussed in OGS that, a VATS should be avoided, but what about other tumors? Can we, go for a VATS if a surgery is required for other solid tumors like E-wings, RMS, or GCT for that matter?
In case of oligo metastatic disease like less than 4, and if they are peripheral, we can definitely try VATS. But what happens, especially in smaller children, we make a little mini thoracotomy, and we are able to actually pull out the lung into the incision a little bit when it is deflated, and we are able to palpate it well. The most important thing is that we should be able to palpate it. So we're doing a complete thoracoscopic approach. The tactile sensation is not there. And some of the lesions can be deep-seated parenchymal lesions, not visible on the surface. So again, you have to assess it case by case depending on the imaging. And if you think you can easily locate it, it's a single lesion, it's a large lesion, which is easily going to be visible. Other thing that comes in the Indian scenario is the cost. So whenever we do a thoracoscopic approach, the cost definitely goes up because we have to use staplers. And the number of staplers per lesion can vary between 2 to 3 to even 4 sometimes. And also when you fire a lot of staplers, you are actually losing out of the lung volume. So a lot of factors are there to decide. My personal preference is to avoid VATS, except in few situations.
Right. Thank you, ma'am. I think next question is for you, Dr. Srinivas. You've answered it in the chat box, but for benefit of everybody, what's the role of radiation therapy in germ cell tumor? Because they seem to be responding well to RT, and it would, be possible to avoid surgery in such a child. So we can't hear you. I think you're muted.
Of course, sorry, there is a data in stage 1 seminoma, active surveillance, single agent carboplatin, and prophylactic radiation to the para-aortic and the pelvic lymph nodes. There is exciting data of stage 2 seminomatous tumors as well. Instead of giving BEP, there is a recent phase 2 randomized trial of single agent carboplatin, even in stage 2. It's not yet standard, but it is now being used more and more often, including my colleagues at TMH started using for stage 2 seminomas as well. This is for primary. But if you talk about metastatic disease, there is almost no role for using radiation. We use it extremely rarely. I think most of the tumors which have residual after the 4 cycles of BEP chemotherapy would be non-seminomatous tumors, which are less sensitive to radiation. And therefore, surgery would definitely be the most preferred approach in these patients.
Okay. I think most of our questions have been answered. I just wanted to ask one question from my side again. Sometimes we are working in setups where we do not have radiation oncologists who are trained to do special, pediatric radiation. So what would you, suggest pediatric oncologist? What kind of discussion would you like us to have with our radiation oncology colleagues? Because a lot of times we find them very resistant to give the dosages which are written in the protocol, or they tend to delay chemotherapies for minor fall in counts, or minor cough cold for that reason. So what suggestion would you give us? How do we convince our colleagues to just go ahead and give radiation?
I think more education, more awareness, more sensitization to radiation oncologists would be the key. I think talking to, I mean, we have no comms, and these are a rare set of patients, and therefore, one must admit that we may be ignorant about it. It is better to call up our colleagues and find out how is it done, when should it be done, when should it not be done, and what doses should be done. Even I've been practicing pediatric radiation oncology exclusively for a few years, but I still call up my colleagues in TMH and maybe in other institutes to find out how it should be done. I think there is no shame in asking our own friends and colleagues to make sure that we are doing the right thing. I think that is what they should also do.
Sure. Thank you, sir. I think I would hand over to Vasudev if I've missed any questions, and he's.
Thank you, Shruti. I think most of the questions put are answered, and I think it's time to wind up. And thank you all the experts who have joined. A few have actually changed the flight schedules as well. So thank you so much, and we will see you again next month, the second Thursday. There's another session, international session, which Dr. Manas has put up, which is on the 28th March. And this will be on pediatric ITP. So I request everybody to join in for that as well. And we will continue this alternate month where we will have hematology and oncology as well. And I would be happy if anyone would suggest any of the topics also. We will look into it and discuss and probably include it in one of the sessions. So thank you everyone, and have a good evening. Thanks.
And thanks to ECO for hosting this session. So thank you, ECO team.
Thank you so much, sir. I think we can wind up this session. I would request all the participants to just fill the feedback form for this session. I have put its link in the chat box, so you can submit your feedback. Thank you everyone.
Thank you, everyone.
Thank you all. Bye.